But the other part which I liked your comment was, if this system is on the lorry, you can take the system to where the community is who does have very least amount of access to the radiation therapy. I think that's going to be a really positive one, because in the world, even in the developed or underdeveloped countries, the access to healthcare is minimized in the rural areas. I think this is an excellent one. And then again, the lorry can be placed anywhere in the center of a wheat field or somewhere in the stadium, and you can send the patient one at a time. I think this is an excellent idea. It's a lot of logistic, but I think it's a really good one. The next question.
I think we give
Go ahead.
Stress when we talk about putting a linac on the back of the lorry, and they think, oh, well, we have to perform quality assurance on it every day, and like, you know, is it going to be a sufficiently stable system? But with hyperfractionation becoming more and more common, I think the idea would be more that you would take it to somewhere remote for like 1 week and give people 5 fractions over that week, and then take it on somewhere else. So yeah, I agree, a really exciting possibility.
Yes, and if they had to do more QC, it's more good for the medical physicists, because more medical physicists will find employment with this mobile unit. Anyway, the next question is, what will be the typical dose per fraction delivered by this system?
Well, at Leo, for proton and carbon ion systems, we're not making the beam lines. That's by separate vendors. But all in all, we're not expecting that to be very different.
The other question is, shouldn't the criteria to choose a treatment modality be the clinical outcome? It's an interesting point.
Yeah, it's a really interesting point, and I think the patient has to have the final say on that. Like, what is most important to them? Is it the kind of maximum probability of tumor control? Or would they really, really rather avoid a certain side effect? Or would they like a treatment position that they can tolerate? You know, if they cannot tolerate lying down, then what can you do? So yeah, I think it's one that we need to kind of address as a multidisciplinary team and include patient views in that team. What is the most important outcome?
So the question is, can you compare your system to PQ system? And if you can briefly tell what PQ system is, that will help the attendees.
Yeah, so PQ are another company pursuing upright radiotherapy technology. In honesty, I don't know a lot about the specifics of their system, so yeah, I wouldn't really like to comment on the differences there.
But PCQ is another company which is also working on its upright system. Am I correct?
Yeah, they certainly have a chair, and they have some form of X-ray imaging system to accompany it, I believe.
Oh, wonderful. The other question is, my question about emergency patient is whether the upright patient upright position is beneficial for them, because it may cause them more harm.
I'm not sure I understand.
It's about emergency patients. I'm not sure emergency patients are rushed into treatment anyways. It's more like this question may be more appropriate to imaging part. So they're telling us, like, if what about emergency patients, is whether upright position is beneficial for them, or it may cause more harm. That's it. It's a general question.
Okay. Yeah, I think your point there is probably spot on, that normally we don't have those sorts of emergencies in radiotherapy. But yeah, it's conceivable that there are patients who this will not work for, who cannot set up on the chair. But equally, there are patients who cannot receive supine radiotherapy. For instance, very obese patients can kind of exceed couch limits. And there have been cases where normal treatment centres have had to treat those patients upright by having them lean on the couch. So unfortunately, there's never one system that works for absolutely everybody, but we're confident that the upright system will work for the vast majority.
I think that leads to the next question, which is similar to one. It's an interesting question. It is seen that some patients lose weight during treatment. That is the supine treatment. What happens in accuracy and position of patients? Do you think that you don't have to demand them to lose weight if you're putting in an upright position?
I think there's no real difference for us there compared to the supine standard. Adaptive radiotherapy is becoming increasingly common, and it's the best way to deal with that sort of issue, really, is if you can adapt your treatment plan day to day to cope with any anatomical changes. And of course, in the Leo solution, we have diagnostic quality CT at the treatment ISA centre, so we really have a nice potential to make adaptive treatment plans based on
that. Leads to another question. With this particular attendees is very excited about the upright radiotherapy. What they're asking is this mean we have a pair with upright CT scanner also? So what is your comment? So you are building a therapy with the CT scanner?
Sorry, was the question like, is
the upright system is also going to have a CT scanner attached to it?
Yes, that is the plan, that in most cases it will be implemented with the patient positioner, and the CT ring will drop down over that patient positioner.
So it's basically like a concentric rings coming inside and taking a CT, and then the ring will move out. Is that the way you're thinking?
The ring moves up and down over the chair like a donut.
Understood. So that the CT scanner ring will move out and the therapy unit will come down?
The therapy unit will be more kind of
fixed.
Yeah.
Or it will be the therapy unit kind of fixed, but the CT scanner ring will, like a Russian doll, rings come in and out.
Sort of, yeah.
It's a really nice one, yes. Let me see. So another one person is really find this your seminar webinar very interesting. The question they're asking is like, are there any limitations for treating around pelvis or lower limbs, as some of the positions seem to limit the beam entry, especially in the anterior direction where the patient is sitting? So how do you account for the table and other things?
That is an excellent point, and it's something that I didn't cover, that if you're in a seated position where your legs are kind of perpendicular to your body, you would definitely have problems with beam access and the beams having to go through the legs. But with our chair, we can adopt what's called a perched position, which is much closer to standing. So the back of the chair is tipped down, and the seat pan is also tipped down, and then the legs are brought down like this and kind of out of the treatment fields for pelvis.
Excellent. There's another question. Okay, this is interesting. So this attendee is already foreseeing a time when the system is going to be installed in the hospital. So the question is, if a hospital is to replace this existing machine with the suggested upright treatment, how does this fare for in terms of QA tools and procedure? Will the hospital can use the already acquired tools, or will they need to acquire new ones? So they're already thinking about what QA tools to buy. That's an excellent question. Yes.
Yeah, it's always great to think ahead. Really, we're anticipating most of the same tools. So you can remove the backrest from the chair, bring the trolley over the base of the chair, and then your water tank would sit on that trolley for all of your commissioning measurements. So in terms of dosimetry, there should be no differences. in terms of mechanical quality assurance, there are of course some differences compared to a gantry, because you have to check the isocentered quality of the chair rather than the gantry. But there's nothing too challenging there in terms of QA differences. And because you're no longer rotating your treatment beam through all the different gantry
ريحة شياط أول ما افتكرت حاجة بتتحرق إيه، بس خلي بالك أنت بتكوي دول ليه؟ ما إحنا ننزلهم المكوى.
That leads to another question. This is also very interesting. How do you treat patients that are body deformity, have in upright position, or how do you do that? If the patient, like a scoliosis patient, that deformity is there.
Okay, yeah, that is a really interesting one, because we've had a few volunteers come and try out our chair, and they've had spinal surgery and other issues, and they actually find it really comfortable when it's used with a vacuum formed cushion. So that's our kind of normal solution, that we'll set them up with that, and that will obviously be tailored to the shape of someone's back, and it kind of aids with our reproducibility as well.
Another interesting question was already forethinking what happens. The question is, are we supposed to relearn everything in treatment planning and setup for both physicist and radiation therapy? So they're already thinking about, should we start doing some learning aspect for this new type of treatment?
Well, the good news is it's all the same principles, it's the same treatment planning systems. So research have already implemented upright treatment planning options, and as long as the kind of coordinate system of your upright CT is correctly interpreted by the TPS relative to the beam, there's really no significant differences around upright treatment planning. So everything you've learned supine will be applicable, and how to generate a good treatment plan will be exactly the same. The bigger differences would of course be for the radiation therapists or therapeutic radiographers who set up the patient. The workflow is going to look a bit different for them, but we're really trying to kind of develop those workflows collaboratively and make them as smooth as possible. So we hope that on the whole there's not a significant amount of relearning that would need to be done. I think if you're an excellent member of clinical staff supine, you would also be that upright.
So this the next question is from the past PC chair of IOM PEDA, and he is asking is like, since he has a lot of experience of treating numerous patients for upright for total body irradiation quite many years ago, the issue of comfort, patient comfort and reproducibility, they found it to be very complex. So how do you compare? In the past, that he has some experience doing this, but they found it to be reproducibility was quite complex. So
yeah, I completely agree with that. In some of our initial work, we've taken supine immobilization devices off the shelf and tried to attach them to our chair, and that doesn't always work well. You need to be quite creative with this, and we're really lucky at Leo that we have both a human-centered design lead and a mechanical engineer who focus exactly on this. How do we make immobilization accessories so that we can keep a person comfortable and still upright? And we're doing a lot of work kind of proposing new armrest designs and so forth to do that. So I think, if you try to use supine solutions off the shelf, it can be challenging, but it's by no means an insurmountable problem. And if you adopt a kind of co-design approach, where we've even brought in physiotherapists to help tell us which body positions are kind of achievable for different people, and kind of really try to bring everyone in the right room to think about the immobilization problem, then we've made fantastic progress with that, and there's a lot of interesting work still to be done there.
This is another interesting question. The current conventional couch we tend to move the tumor to the isocenter of the rotation of the treatment machine. Will this new system allow a similar approach, but moving the patient relative to the machine, or is there something more advanced by moving the collimation to achieve something similar? It's interesting. Whether you move the patient or you move the whole system.
The plan is generally that it will be similar, that we'll move the tumour to the isocenter. So the rotating chair is on a platform which raises and lowers to do this.
And it also goes left and right in all directions, the table?
Yes.
So that you're aiming to position the patient treatment site as the isocenter. Okay. The next question is let me see. Okay, these are the attendance question. We'll answer it after. Okay. Radiation delivery is with a fixed ring linac, but with the rotation of the patient. Is that what this question is about? How many degrees of freedom is possible with the standing patient support system?
The Leo patient positioner has 6 degrees of freedom. Left, right, pitch, or
okay. So the question they're asking is the radiation delivery is with a fixed ring linac, or is it going to be and rotating the patient?
Yeah, it's a fixed linac, so fixed treatment beam, and then the patient then rotates through the beam.
Understand. Okay. So the patient platform will rotate.
Yeah, the rotation is very slow. It's 1 revolution per minute. And if you try to do that yourself on an office chair, it feels incredibly slow. You basically can't do it.
Okay.
People respond really positively to that rotation. On the whole, they don't even notice that it's happening. It's a very smooth motion.
One other question is, can we deliver total body irradiation with upright position?
It's not something that we've focused on to date, but it's been done historically, and yeah, it should in many ways be easier than supine, I would say.
So, question here is one second. Give me. Some of the question is related to the CMA, which we will answer separately. Can the desired beam characteristic be measured with the currently commercialized dosimetry system, or do they need to have a different dosimetry system?
I think that's the one we've already covered, where we say, yeah, you take the backrest off and then you have a trolley to put your water tank on.
Okay. The other question is, I think you already answered the 6 degree of freedom on the table question. So in the current system, this is another question. There is a choice of non-coplanar beam direction. In a standing paradigm, would not the choices be limited to one plane?
Very interesting question. You've got kind of 2 possibilities there. Either you try to introduce a bit of flexibility in the beam line, so you have slightly different angles in your treatment beam, or you do that with the patient positioner, which we can do to some extent with our chair, but not a great deal. But my personal opinion is that non-coplanar fields aren't used very much in radiotherapy, and kind of with more conformal arc-based therapies, we're generally moving away from that.
The another question is, what do you expect in terms of reducing fixation devices and hence immobilization cost? Will it reduce?
Yeah, I think that is sort of open for debate, really. It of course depends on the vendors of the immobilization devices, and I think for both upright and supine there's probably scope to reduce the cost of accessories in radiotherapy, but it's not something that we've particularly explored to date, I would say.
Another good question, appreciating your presentation. I just want to express all those questions written by these attendees. Start off with appreciating how excellent your talk is. So I just want to paraphrase. The next question is, do you think upright treatment could be better for patients affected by multiple myeloma?
Multiple myeloma. I'm afraid it's not something I know much about, so I wouldn't like to comment on that one. Sorry.
All right, because a lot of the time in the multiple myeloma patients also have very brittle bones and movement, other things. So, okay, I think you already answered one of the question: how to maintain the patient position? Can we use fixation system? That is like so.
Yeah, there are a lot of options there. Really, in that study that was performed in Lyon for the pelvic patients, they added a belt, which the patient found quite comfortable and kind of reassuring. And yeah, we could add sort of straps potentially, and the arm supports, like we've already mentioned. It's just a world of possibility.
Yeah, another question is also interesting. Could the irradiation be done with a tomotherapeutic approach instead of a fixed beam geometry? Like in the whole thing, the beam moving around.
Yeah, that's very interesting. Kind of swap our CT ring for a tomo ring with a person upright. Why not? I guess it would kind of increase the cost relative to fixing the beam though.
So this is another question asking is like, using a CT for imaging for positioning, how does this affect patient doses? And this is like all the imaging done with the therapy. The question is it going to change patient doses, increase or decrease or something like that?
I like that question because of course normally we have fan beam CT solutions in treatment room, but actually fan beam techniques often lead to a higher, we have cone beam in the treatment room. And cone beam techniques, so we're really hopeful that by having our fan beam CT in the treatment room, we can actually bring down the imaging dose.
So now the other question is how with the TPI case and a total skin case, total skin?
Yeah, that one we already kind of touched upon. It's not something we've looked into yet, but we don't foresee any big problems there.
Another question is, how can you achieve tangential beams in upright position?
Well, that one is through the patient rotation, that you do your first beam and then rotate the patient through 180 degrees and you would have the perpendicular beam.
Similarly, they're asking us, can we use wedges here?
There's a move away from wedges in linear accelerators generally, and yeah, that's not something that we'd be considering.
So another question is, horizontal position is the best natural position for any sick person, except in cardiac congestive state. For example, how would you require immediate? How do you immediately tilting of patient in erect position to horizontal position? Is erect radiotherapy or CT taking care of such emergencies? You know, we are doing upright and then you lay it down. That's the question. I'm trying to paraphrase the question.
Oh, so if someone has a medical emergency while they're on the chair, yes, so we are developing a kind of emergency evacuation procedure, and that would be kind of down to therapist training how to get them off the chair safely and onto a wheelchair, for instance. But I mean, it's also a challenge for supine radiotherapy, getting the patient off a couch that's raised up in an emergency.
I think you already answered this question, but I just want to repeat. Could you please comment on the treatment time? And since the patient is moving instead of the gantry, what will happen if the patient feels uncomfortable during the movement or something?
So the patient rotation is matched to the normal gantry rotation speed, which is 1 revolution per minute. So in terms of treatment time, it should be very similar. What was the second part of the question?
Just like, will the patient feel uncomfortable when they're moving, motion?
Yeah, so it's so slow at 1 revolution resolution per minute that they'll barely notice it. In the future, there is a possibility for us to look at increasing that speed to reduce the treatment time, which could be quite nice for conducting a treatment during a breath hold, for instance.
So one final question. What is the SSD used here and how much we can treat at extended SSD?
Yeah, for a LINAC-based system, that can be quite flexible, really, in terms of where you put your treatment head relative to the chair. So yeah, there's a possibility to change the SSD there.
I think we are top of the hour. I'd like to close it. I want to express my sincere gratitude on behalf of IOMP and myself for you taking the time to provide us this particular talk, which is really exciting as there are hundreds of questions. We try to answer as many questions as possible. With regard to some of the questions of this attendees question, there is a link in the Q&A area on the answer part. You can check that link before you leave the webinar, and you can access the certification for this attending this particular webinar and any other webinar you have attended in the IOMP. And this webinar is recorded and will be available on the website soon as we get to work on this and submit it. I think we had an excellent conversation, especially thank you for not only providing the representation, but also providing a lot of interesting questions, answers to a lot of interesting questions. Thank you, and I wish you and your group the best, and looking forward to see you at the Upright Treatment Center or in a city near me or something like that. Thank you.
Thank you so much for all the organisation around these meetings, and to all the participants for their questions, which were absolutely brilliant and made me think a lot.
Yeah. Exactly, and I also want to thank the main organizer is Dr. Eva Besek, and I was just asked to moderate this session, and I want to thank her also for forwarding. I also want to thank our Secretary General, Dr. Magdalena Stova, who maintains behind the scene all this recording very smoothly. And of course, I want to thank our President, John Damalakis, who is one of the main motivationers, was stalwart behind this whole IOMP webinar and IMPW webinars. Thank you very much, Dr. Tracy, and good luck. Thank you.
Thanks, everyone. Bye.
Good night. Thank